Good morning, everyone. Welcome to Tyro Multidisciplinary Seminars. It is our usual Friday morning session, and it truly is an international program this morning, talking about a really important topic that all of us as clinicians dealing with thyroid disease invariably encounter. We literally have a panel from across the globe with Professor John Wadsley, reporting from Europe. He is a consultant clinical oncologist at Weston Park Hospital in Sheffield. He has clinical interest in thyroid cancer, neuroendocrine tumors, pancreatic and biliary tract tumors, and he has particular interest in molecular radiotherapy. Dr. Wadsley has a particular clinical focus in thyroid cancer and neuroendocrine tumors, and he is clinical director of the Sheffield Cancer Clinical Trials Center. He is also the NIHR National Specialty Lead for Radiotherapy and Imaging. Our discussant this morning is Dr. David Pattison, who is a member of the Tyro Medical Advisory Board. He has been a frequent member of the panels on Friday morning. He is both a nuclear medicine specialist and incredibly also specialty trained in endocrinology. I dare say, David, I think there must be very few of you with those credentials across, at least in this on this planet. I don't know about anywhere else in the universe. He is the director of the Department of Nuclear Medicine and Specialized PET Services at Royal Brisbane and Women's Hospital in Australia. He also has an academic appointment at the University of Queensland, and he has research interests, including molecular imaging and radionuclide therapy of endocrine malignancies, including thyroid and neuroendocrine tumors. And so this morning's discussion is really going to be focused on what do you do? How do you manage? How should we think about incidentally discovered FDG Avid Thyroid Nodules? There's been quite a bit of an evolution in the thought about this, and I think it's extremely timely that we go back through and understand what the current thoughts are with this entity. And so, as always, I encourage our listeners to send in their questions. I will do my very best at the end of Dr. Pattison's discussion to get to all of those questions. And so with that, I'm going to go ahead and have Dr. Wadsley start the presentation. And once again, thank you, David and Jonathan, for joining us this morning.
Well, thank you for your very kind introduction. Going to be discussing this morning this paper that a group of us in the UK put together and was published a bit earlier this year, trying to provide a consensus statement on how to manage incidentally discovered FDG Avid Thyroid Nodules, specifically in patients who are being investigated for other cancers, which is obviously a very common way in which these things turn up. So these are my disclosures. Just to give a bit of an overview of the background to this paper and why we felt it was needed, I'm sure everybody will be aware that there's an increasing problem really with overdiagnosis in thyroid cancer, and I'll show a bit of data on that shortly. But it is becoming a big problem that we're identifying many more low-risk thyroid cancers, and it's challenging to know quite what to do for the best with some of these cases. So what we set out to do is review the evidence for outcomes for patients with FDG Avid Thyroid Nodules, and to generate some recommendations specifically in the context of patients who have these nodules in the context of another malignancy that carries a poor prognosis. So just to rehearse the problem of overdiagnosis, I'm sure everybody will be familiar with the data that's come from South Korea, where they introduced an ultrasound screening program for thyroid cancer. What that did was massively increase the incidence of thyroid cancer, demonstrated by the blue line here, but actually made absolutely no difference to the mortality, demonstrating almost certainly what we're doing by a screening program is identifying low risk thyroid cancers that were never going to be a clinical problem, but not actually influencing those more serious cancers that cause mortality. And that's been demonstrated really across the globe. This study from Lancet Diabetes and Endocrinology a couple of years ago demonstrates the increase in different sorts of thyroid cancers in many different countries. Interestingly, there's variability between different countries, but almost every country we're seeing an increase in those low-risk papillary cancers that are demonstrated by the blue line here. But actually, the cancers that can prove lethal, the follicular, medullary, and anaplastic cancers, really very little change in incidence over time. So what are the causes of this overdiagnosis? Well, we've already mentioned the screening in South Korea, but also, again, as I'm sure we all recognize, the increased use of medical imaging generally is leading to us detecting many more incidental lesions. And a large part of our specialist thyroid cancer multidisciplinary team meeting is taken up with discussing these incidental findings these days. So there are numerous ways: neck ultrasound scan for other reasons, patients having MR scans of the spine, but also pertinent to this particular discussion, the increased use of FDG PET, very commonly in the staging of other malignancies, but also obviously with other indications in inflammatory diseases and etc. And the images here just show some examples of incidental FDG uptake in the thyroid, demonstrating the different sorts of patterns that we see. So why is this a problem? Well, it does cause quite a lot of almost certainly unnecessary anxiety. Patients are already being investigated for one cancer and they're told they might have another. Probably more worryingly, it potentially leads to overtreatment and potentially surgery to deal with these incidental findings that probably has no impact on quality or quantity of life, but actually may have adverse effects on quality of life because of the side effects of the surgery and risk of complications, and clearly costing the healthcare system more money. So overall, we felt that a lot of the time there's no overall benefit to investigating or managing these things, and actually likely harm being caused by that. So, as I said, this is the paper that we put together, the goal being to produce evidence-based guidance regarding whether or not it's necessary to investigate these incidental FDG Avid nodules in patients with other cancers with a poor prognosis. So we set up a multidisciplinary group, so that included representatives from oncology, endocrine surgery, head and neck radiology, and endocrinology. And we reviewed the relevant literature and agreed a consensus statement regarding the management of this group of patients. So firstly, we looked at what the incidence of FDG Avid Thyroid Nodules is. So meta-analyses suggest that if you look across all FDG PET scans, around 2.5% have incidental thyroid uptake. It is widely held that FDG uptake in a thyroid nodule does predict for increased risk of malignancy, but the malignancy risk in these incidentally discovered nodules is controversial, and there have been widely different estimates in different publications. So a meta-analysis has suggested that malignancy risk could be as high as 35% if your thyroid nodule is FDG Avid. But we recognise that there's significant selection bias in that not all of these nodules are either biopsied or indeed resected. So in many cases, we don't actually know how many cases have malignancy and how many are benign in a definitive way. And indeed, one series of nearly 2,000 FDG PET scans identified 65 of these thyroid incidentalomas, but actually only 2, so that was 3%, were actually confirmed to be cancers. And we felt this is probably a more realistic estimate of the incidence of certainly of significant cancers within these incidental FDG Avid nodules. There are clearly different patterns of FDG uptake, some which might be more worrying than others. So when you see diffuse FDG uptake in the thyroid gland, that's much more typical of a benign inflammatory condition, and biochemical testing would be recommended to confirm that. Focal uptake is much more of concern, and there is a risk of malignancy, but we know there are benign lesions that can be very avid, in particular oncocytic lesions, because of the number of mitochondria in these tumors, are often very fiercely FDG avid. There's a question about whether the intensity of uptake is relevant. In that intensely avid lesions are thought to be more likely to be malignant, but no study has ever managed to establish a standard uptake value threshold for malignancy, and there's definitely overlap between malignant and benign lesions. So although the more intense the lesion is, the higher the risk, there's not, we can't really set a threshold below which we don't need to worry. In terms of correlation with histopathology, papillary cancers are obviously by far the most common type of thyroid cancer. We know that FDG avidity is inversely related to the ability of the cancer to take up iodine. But either way, if papillary cancers are less than 4 centimeters in size, these are generally considered low risk cancers and very low risk of causing cancer-related harm. They generally have an excellent prognosis. Follicular or oncocytic thyroid cancers typically are very FDG avid. Medullary cancers obviously rare, but these have variable FDG avidity. And anaplastic cancers usually would be expected to be FDG avid, as they're clearly very aggressive malignancies. But realistically, these are unlikely to be detected as incidental findings, because usually these patients are very symptomatic very quickly from their cancers. So in terms of further investigation, if it is felt to be warranted, clearly ultrasound would be the first line investigation to further evaluate these thyroid nodules, and ultrasound is useful for risk stratification and determination as to whether further investigation is required. We'd recommend the use of a recognised risk stratification in the system. In the UK, that tends to be the British Thyroid Association risk stratification system. Clearly, TIRADS is perhaps used more widely internationally. And the recommendation is that FDG Avid Thyroid Incidentalomas that are confirmed to have benign features on ultrasound do not require further either fine needle aspiration biopsy or any further follow-up. So the fact that they're FDG Avid, if ultrasound features are benign, we can be reassured, and the evidence suggests that we don't need to do any additional investigations above what we would normally do for any other thyroid nodule with those ultrasound appearances. Clearly, if there are concerning features on ultrasound, we may then take a decision to do a fine needle aspiration, but that should not be taken lightly. We know that, many fine needle aspiration biopsies are non-diagnostic. They may fall into, in the UK, what we call a Phi3F category, and that would lead to diagnostic surgery. So we need to think carefully about whether that would be appropriate in the given patient, given their underlying other malignancy. So we also reviewed what the existing guidelines had to say about this. So the British Thyroid Association guidelines from back in 2014 do comment on this scenario. They recommend that nodules detected by FDG PET should be investigated with ultrasound unless disseminated disease is identified and the prognosis from an alternative malignancy would preclude further investigation. So I think already a hint towards what we were proposing, that patients with advanced other malignancies don't need these nodules investigating a great deal. The American Thyroid Association guidelines of 2015 give a little bit more detailed advice. So they talk about what to do with patients with essentially functional nodules with suppressed TSH. They do recommend fine needle aspiration of FDG Avid focal nodules that are not TSH suppressing. and don't really give any guidance as to the appropriateness of doing that or otherwise in the context of other malignancies. So at the end of our paper, we established some recommendations on the basis of this evidence review. So as a general approach, we recommend that consideration is given to the age of the patient, the prognosis of the primary cancer, the patient's comorbidities, the characteristics of the thyroid uptake, whether it's diffuse or focal, and really importantly, the patient's understanding of the situation and their wishes. But as a general principle, we feel that if a patient is considered unlikely to survive 5 years, then further investigation of incidental FDG uptake is unlikely to be appropriate. However, if the prognosis is subsequently revised as a result of a good response to treatment given for another cancer, then further investigations perhaps should be reconsidered. Regarding the decision to investigate these lesions further, we felt this should be considered if the thyroid lesion might actually be a metastasis from the primary cancer, which might alter the management of the primary cancer and mean that maybe that cancer was no longer radically treatable. Lesions more than 4 centimeters and very avid, we felt were at more risk of causing the patient thyroid cancer related problems, and consideration should be given in some circumstances to investigating them. Where the thyroid lesion might actually be the source of metastatic disease, so the thyroid is the primary and the disease that's been seen elsewhere is a thyroid metastases, or situations where the prognosis is likely to be better than 5 years, where the patient may have a longer life and long enough to run into problems from a potential thyroid cancer. So in these circumstances, absolutely, we would recommend further investigation. So we put together an algorithm. So this was really for the benefit of other cancer MDTs who clearly regularly come across these incidental FDG PET Avid thyroid lesions, to give some guidance about when these need to be taken seriously or essentially when they can be ignored. The hope being that this might reduce the number of inappropriate investigations instituted by those other MDTs and save patients unnecessary worry. So the algorithm suggests that if the patient has an active cancer or life-limiting condition without a reasonable chance of living more than 5 years, then further investigation is unlikely to be warranted. If that's not the case, however, they should go on to have a thyroid ultrasound, and then depending on the findings of the ultrasound, may or may not need a biopsy. So I'd like to acknowledge colleagues from the UK that work with me on this project and this publication.
All right, so I'll be providing a bit of additional background to Jonathan's presentation today. And FDG Avid Thyroid Incidentalomas have been a particular area of interest of mine, over several years. These are my disclosures. And really, I think there has been a significant evolution of the way that we think about FDG Avid Thyroid Incidentalomas, over the last sort of, almost 10 to 15 years. In my talk, I'll be initially reviewing the ATA guideline recommendations, and then predominantly focusing on these focal thyroid FDG uptake, where we have to consider, one, the thyroid lesion and the nodule characteristics to identify patients at higher risk to potentially benefit from further investigation. And so this is particularly looking at local features, such as if there's the presence of adjacent FDG Avid nodes or other features suggesting high-risk thyroid cancer, or if this is indeed the primary tumour. SUV max is a consideration, and I'll explore that in this presentation. And then, very importantly, tying in with what Jonathan has discussed, we have to consider the clinical context and the patient characteristics. And this, in fact, has been an area of my research where we seek to identify patients who've got a poor prognosis who are unlikely to benefit from further thyroid investigation, and particularly consideration given to the prognosis of the underlying malignancy, in particular its FDG avidity, stage, and other comorbidities. And in that setting, we should have a real consideration for active surveillance if the nodule does undergo further investigation and it is a malignancy. It's a cohort of patients that active surveillance can be quite appropriate. So we've actually heard already about this, so I won't spend much time on the ATA guidelines. But essentially, focal FDG uptake is considered to convey an increased risk of thyroid cancer, and FNA is recommended for those nodules that are over 1 centimetre. And with diffuse FDG uptake throughout the thyroid, this often signifies thyroiditis, so correlation with thyroid function tests is recommended. I'm going to go back. This is actually a case that really spurred my interest in the area. So I'll just give an overview of this. So it's a 75-year-old woman who had high-grade lymphoma. This was the staging PET. You can see there's very intensely avid, cervical nodes involved with the lymphoma. And there was also this intensely avid thyroid lesion with similar avidity to the lymphoma. It was stage 1E. It was eroding the mandible and was treated with CHOP chemotherapy. This was an interim PET done a few months later, where there's already been a complete response of the lymphoma, and an end of treatment PET, much the same, persistent focal intensely avid thyroid lesion, resolution of the cervical nodes. And at this point, the patient underwent further investigation with ultrasound and FNA. This is what was found. So that lesion, it was sort of just adjacent the right lower pole and isthmus. It was very intensely avid, so SUV max of 36, and on biopsy, it was a Hürthle cell neoplasm. And this is sort of putting everything, it took quite a while, and it took actually all of the surgical pathology to piece all this together. But when you look carefully at the scan, more superiorly, there was this mildly avid nodule at the right upper pole, and that had a much lower SUV max of only 3. And following eventual resection, this was actually confirmed to be a papillary thyroid cancer and with BRAF V600 mutation. It was actually really an incidentaloma, because the original hemithyroidectomy was performed for that very intensely avid lesion. And this is back in 2011. People just thought, it's so hot, it's got to be cancer. But so they proceeded appropriately in that circumstance to have a hemithyroidectomy. But then when I went back to review the case later, I paid particular attention that the initial lesion was a Hürthle cell neoplasm, but the eventual malignancy was a BRAF positive mutant. And then we analysed this more out of part of a subsequent research project, and it showed that differential finding. And it was really piqued my interest in the area, that you could have an incidental finding of malignancy in the setting of an FDG Avid incidentaloma. So a bit of background, this is a major meta-analysis that was done that just provides data from a cumulative amount of over 150,000 or nearly 150,000 patients, and shows those figures that have been quoted widely, that there's an incidence of thyroid incidentalomas in about 2.5% of PET scans, and about 35% of these, there's variable numbers in different studies, are considered to be malignant. But there is marked statistical heterogeneity between the studies, and the range of malignancy incidence, as Jonathan's pointed out, varies widely. And in this meta-analysis, it varied from 8% to 55%. So it does raise the awareness of biases. So one of these is verification bias, whereby, of those original studies in the meta-analysis, there was limited histologic verification, either via FNA or surgery, of those FDG Avid Thyroid nodules. So this, and in essence, was only a median of 54% of these were actually investigated. So there's unmeasured clinical, radiological, or biochemical risk factors of malignancy. And the pretest probability of malignancy in those nodules undergoing further investigation may well be quite different to those that are not investigated. So we still aren't 100% sure of what the true incidence of malignancy is in this setting. And also, this relates to the case that I just presented before. There's the issue of misclassification bias. So we have the potential for incidental identification of occult thyroid carcinoma in the thyroidectomy specimen. Now, it's not actually corresponding to the original site of concern in focal FDG uptake. So you can have both histopathologic and imaging incidentalomas. And we know from autopsy studies that these can demonstrate a high background incidence of typically small thyroid carcinomas. In fact, in patients over the age of 60, there's up to 36% of these can have occult thyroid carcinoma on fine cut histopathology. But the majority of these are clinically insignificant microcarcinomas that would never go on to cause problems. And these are the kind of malignancies that are identified on these screening studies from Korea. And also there was one study in that meta-analysis where they excluded 4 incidental microcarcinomas because it was felt they were clearly not associated with the imaged abnormality because of this partial volume artifact, etc. And of course, this was a study done in 2007 with quite low resolution PET cameras. And that actually, just excluding those, because they were unlikely to have been able to be imaged, it reduced the overall incidence of thyroid carcinoma in that series from 32% down to 14%. So again, that aligns with what Jonathan's told us already. And so with histopathologic and imaging correlation, we can get, this is just relating to a study that I did with colleagues back in 2015, where I was looking at a detailed histopathologic and FDG PET correlation of the size, location, prognostic markers in 24 consecutive incidentaloma cases. Now, 20% of these, so there were 15 patients who we actually had a confirmed diagnosis, and so 20% of, so 3 of the 15 presumed malignant FDG Avid Thyroid incidentalomas were not malignant on review on this detailed correlation, in which 2 of the cases, the actual Avid focus was actually proven to be benign on this careful histopathologic correlation. And in one case, the diagnosis was revised. It was a patient who actually had what was originally described as a Hürthle cell carcinoma, but there was no invasion found on the subsequent review, and it was actually considered to be an adenoma. Just moving forward. Overall, so of the 13 malignancies, PTC was 7, 5 were oncocytic, and 1 was a medullary thyroid carcinoma, and 11 of these were benign. A large proportion of these were oncocytic, and there were also other findings as well. And interestingly, in this, in our series, there was no SUV-max cutoff, and predominantly driven by the very avid oncocytic adenomas. They were actually, the benign cohort was actually more avid, or the median was more avid than the malignant patient cohort. So what about thyroid oncocytomas? This comprises both Hürthle cell adenomas and carcinomas. Typically in our practice, we're really just predominantly focused on Hürthle cell carcinoma, but it's important to consider in this context of focal FDG uptake that's incidental, that Hürthle cell adenomas are a very common driver. And there's numerous case reports of this, and we know that Hürthle cell cytology as well is also associated with intense FDG uptake. And when we look at oncocytomas or Hürthle cell histology, we know that it comprises abundant granular eosinophilic cytoplasm, which represents mitochondrial hyperproliferation. And the minority of Hürthle cell lesions are actually malignant. The majority of these are actually benign adenomas. Just moving forward. This is relevant to the mechanism of FDG uptake in general. So in cancer, the Warburg effect or aerobic glycolysis in malignant cells is the key characteristic with this inefficient metabolism that drives greater glucose uptake and drives FDG uptake, and is the basis of the use of this as a PET tracer for cancer staging. However, in more differentiated tissues, so this is either normal tissue or non-malignant, such as adenomas, where in normal tissue, it's generally the most efficient. So oxidative phosphorylation is very efficient, generating a lot of ATP for each unit of glucose. But in the setting uniquely of oncocytic pathology, we actually have a mitochondrial defect, which actually drives anaerobic glycolysis, which is much less efficient. And as a result, there's much greater glucose and therefore FDG required to generate any unit of ATP. And in fact, this has been found in the mitochondrial respiratory chain that actually complex 1 is the hallmark of the oncocytic phenotype. And it's the common mitochondrial defect in oncocytic tumours, which, as we know, it's not just in the thyroid with Hürthle cell, but there's also Warthin's tumours, renal oncocytomas, etc. And interestingly, if you look across here, it's relevant for the practice of pheochromocytomas. It's succinyl dehydrogenase or SDH mutant paraganglioma and pheo. That's where the defect is, of course, in the mitochondrial respiratory chain, and that explains the very intense FDG uptake we also see in those malignancies. Just moving forward. And again, these are just a couple of cases from my own series of, very FDG avid, histologically proven oncocytic adenomas. Moving on, this is another area that Jonathan has raised, but the absence of an SUV cutoff between benign versus malignant FDG avid incidentalomas. So here's a series, this is a meta-analysis looking at all of these series. And a lot of this work was done, it's been done since the 90s and early 2000s. But you can see some of these show a significant difference, but the majority actually don't. And in fact, there's numerous potential explanations, including, we know that SUV is influenced by differences in image acquisition and processing and technology. But there's also considerable SUV-max overlap between those benign, or including the oncocytic causes, and also the malignant ones. We know those oncocytic tumours can be very, very avid, and that can really be a key driver of that lack of a cutoff to guide this. And so the recommendation from the ATA guidelines is certainly to treat according to the ultrasounded cytology and not to assume that FDG avidity equals malignancy risk. Now, I think with the ATA guidelines, that's not so much of a concern now, but certainly going back 10 or 15 years ago, when this was less well characterized and understood, there were people who just felt it was, these lesions were so FDG avid and irrespective of the FNA, sometimes these were resected. This just brings me to a paper that myself and colleagues published in 2017, which is looking at the importance of contextual interpretation of FDG avid thyroid incidentalomas. And so this is where we looked at all PET-CT reports. We used a search term to identify all FDG avid incidentalomas, and ultimately we identified 500 of these. And then we needed to find, we required patients to have more than 12 months follow-up after that index PET-CT or death, and ultimately ended up with 362 of those 500 lesions seen on PET scans with adequate follow-up to be included in the study. And that 12-month follow-up was that if there was any significant adverse outcome from that FDG avid thyroid incidentaloma, that would be captured on that subsequent history. And variables that we looked at, included the primary malignancy, AJCC stage, FDG avidity within the primary malignancy, extent of thyroid investigation, etc. Just move on now. And so in summary, the findings, without going into too much detail, there was a median follow-up of 24 months. The median overall survival of this whole cohort of patients was only 20 months. So clearly these patients, this is at a comprehensive cancer centre at the Peter MacCallum Cancer Centre in Melbourne. The patients who are having PET scans for investigation of malignancy have a poor prognosis. And that mortality was due to the primary malignancy in 92% of patients, other non-malignant causes in 7.2%. And there was one patient in this series that actually had a medullary thyroid carcinoma who actually passed away from that malignancy. And so it's a 0.6% incidence, which is very, very low of actually having clinical impact from the thyroid incidentaloma. The vast majority of the thyroid cancers that were identified, there was actually no significant disease at the end of follow-up in the study for those. So the thyroid nodule was investigated in 131 of the 362 cases. Of that cohort, we found malignancy in 36%, in 47 of them. The majority in this series were papillary. 11 had malignant FNA, but underwent surveillance, so we didn't get final histopathology. There were 5 oncocytic or Hürthle cell carcinomas, 4 metastases from the primary malignancy, 2 medullary thyroid carcinomas, and 1 follicular. This is the main analysis. We were looking at what those predictors were of mortality, and we found, most importantly, with a hazard ratio of 8.5, the presence of FDG avidity in that underlying non-thyroid malignancy was a very significant prognosticator for mortality and death. And so the key finding there is if the patient, if they don't have any FDG Avid other malignancy there, and this relates to what Jonathan said as well, it's appropriate, that's a cohort to consider further investigation. But if your patient has got, significant FDG Avid disease from another malignancy, it's just a cause for concern and to really revisit the prognosis and whether you should be necessarily investigating that thyroid incidentally at that point. The other things, so clinical decision to not investigate the thyroid, and this is really the clinicians make that decision, and this supports that it was a significant predictor of overall mortality, because the clinicians decided, well, actually, the underlying malignancy is more significant. I'm not going to bother investigating the thyroid incidentaloma. And then this was AJCC stage, as would expect. This is of the primary malignancy, and showing that, of course, it just supports the AJCC staging of that intercurrent malignancy and prognosticating for overall survival. This is one of the cases which is just quite typical. It was a patient who it was actually unfortunately a young patient with metastatic cervical carcinoma. They had this FDG Avid incidentaloma in the right thyroid. It was investigated. They underwent total thyroidectomy. They actually then went on to have radioactive iodine. And in fact, the vast majority of this patient's investigation and management was actually management of the thyroid cancer after they had their initial treatment of cervical carcinoma. But unfortunately, there was further progression, and this patient actually passed away, several months later. And so it was just highlighting just one case to highlight that, we are dealing with an unwell population in this setting, and to be aware of that underlying, poor prognosis from active malignancy. This is actually the patient who ended up having a significant thyroid carcinoma. So on the left is the FDG PET scan that showed there was a non-avid duodenal net, and there was a intensely avid Hürthle cell adenoma. In fact, in the left lobe of the thyroid, there was a mildly FDG Avid lesion in the right lobe of the thyroid. That on a dotatate PET scan performed at the same time. That lesion was actually mildly dotatate avid. The Hürthle cell adenoma was not dotatate avid. And there you can see that duodenal neuroendocrine tumor that's intensely dotatate avid. And, unfortunately, this is several months later, but at this point, there'd been progression of that just mildly avid medullary thyroid carcinoma, and there was development that was resected at that point and further investigated. But unfortunately, that patient developed extensive bone metastases and passed away. And just out of interest, the intensely avid lesion on the left was actually biopsied earlier on in the process and was shown to be a Hürthle cell lesion, but the less avid lesion on the right actually wasn't biopsied. So just in summary, looking at FDG and prognosis of incidentalomas. So this is just an interesting observation that unlike in the setting of metastatic thyroid carcinoma and also in other, virtually all other malignancies, FDG avidity does not appear to add prognostic value in this cohort beyond the TNM stage. So in the setting of incidentally detected thyroid cancer that's subsequently biopsied and treated, this was a study showing that it doesn't actually have prognostic value. And just one hypothesis there is that misclassification bias may be the explanation. And so really, we should, when thinking about investigating FDG Avid Thyroid Incidentalomas, these were some of the take-home messages, were to consider the prognosis associated with the underlying PET indication to determine the need for further investigation, to treat according to the FNA result, not the FDG uptake, to avoid delaying therapy for the primary underlying malignancy, recognising that the nodule may be observed on serial imaging, particularly those patients that have PET as part of their standard follow-up, and in the setting of confirmed thyroid cancer, to consider all of these factors and certainly, if appropriate, to consider active surveillance. Diffuse thyroid FDG uptake. So we know that this typically is associated with Hashimoto's thyroiditis and other inflammatory conditions. And so, and also to recognize, though, that the thyroid FDG uptake may precede the change in thyroid function tests, and that's something that I've noted. And so to always check the thyroid function tests and antibodies in this setting. Just going to reiterate again Jonathan's paper's approach for investigation of FDG Avid Thyroid Incidentalomas. So to consider that they're active cancer or other life-limiting condition, and assessing whether there's likely to be a prognosis beyond 5 years, and including one consideration there is the FDG avidity and the underlying malignancy. And if any of those, if the answer is yes, then to recognise that further investigation is unlikely to be warranted. But if it is appropriate to undergo further investigation, thyroid ultrasound, and then to look at based on those findings, to, if appropriate, to pursue FNA and to consider either active surveillance or active therapy. So in final conclusion, we know that about a third of these FDG Avid Thyroid Incidentalomas are malignant, but there is some variability from different studies. There is no SUVmax threshold for investigation, unfortunately, because we know that the Hürthle cell neoplasms are characterised by a very intense FDG avidity, so it limits having an SUV threshold. We do need to consider the prognosis associated with the PET indication. Active surveillance may well be appropriate management, and to also avoid delaying therapy for that underlying malignancy. If appropriate, investigate with ultrasound-guided FNA. And I'll leave it there, and we'll open it up to the floor for questions.
That is, thank you both very much. That was absolutely terrific discussion here, and I think provides a really very important clinical context. I do remember there was a time when we thought that there was close to a 50% risk of malignancy at the very outset, when we recognized that thyroid nodules were hypermetabolic. Dave, John, let me just see if you have any comments at all on David's discussion here.
I think we were both really very much singing from the same hymn sheet and giving the same message, that the careful thought is needed. That some of these nodules can be significant malignancy, but even if they are malignant, active management isn't necessarily required, and consideration needs to be given to active surveillance in appropriate circumstances.
And just one other comment, just to add there, if I may, just the importance of having all the clinicians on the same page with this is really important, because and so we try to be consistent, and we leave the door open in our nuclear medicine PET reports. We aren't too prescriptive in saying this lesion must be investigated, for example, with ultrasound and FNA, because that can sort of leave clinicians with their hands tied. And we will provide a little bit of nuance. And so sometimes if someone's clearly got, aggressive metastatic melanoma or some other condition, we may just phrase it more by saying, that there may be an underlying neoplasm, but of unlikely or of uncertain or doubtful clinical significance in this context. But yeah, it's important to have the endocrinologist, surgeon, oncologist, all on the same page, so there's no uncertainty for the patient if there is a decision to undergo surveillance.
Great. I wonder if you could just, I don't know if the data supports this, but if you were to eliminate Hürthle cell lesions, can you then rely upon the SUV threshold? Or is the data too thin to make a comment on that?
Is that to me or Jonathan or either?
Either one.
Yeah. Look, from my reading, I haven't looked at that specifically. I do remember looking at that, 5 or 10 years ago, and I don't think that I think it would be better, but I don't think anyone's defined an actual threshold that we can use. But I agree that would resolve some of that issue. And I think if it's not a Hürthle cell lesion and it's very, very avid, so we can't just sort of say, if it's above 5, then it's malignant. But, if it was above 10 in that setting, it would be more concerning. but I don't think we have we don't have a clear cutoff.
So you both commented on FDG avidity of a thyroid nodule or of metastatic disease, which is widely recognized as for thyroid cancer as being a not well differentiated disease and unlikely to trap iodine, but that the corollary doesn't hold true for these incidental thyroid nodules that are FDG Avid. I wonder if you could comment on that. This is somewhat of a disconnect here. Is there an explanation for that?
So I think it probably does go back to David's point that it's the Hürthle cell lesions that are probably driving a lot of that incidental FDG uptake that's seen, rather than papillary or follicular lesions that you would expect to be iodine avid. So I think that it has to be something to do with that is driven by very, very avid oncocytic lesions in the localized incidental group, where in the context of metastatic disease, the FDG avidity obviously is a differentiation marker and indicates aggressive cancers that are less likely to respond to iodine.
But yeah, go ahead, David.
Oh yeah, no, I was just going to say, yeah, I mean, it's a real paradox, and it's difficult to grasp. But I agree. I think it is partly that mixed bag of patients. I think another element. I mean, my best explanation for it, I think, is this misclassification bias. So having looked very closely, I had our histopathologist to go through all of the thyroid specimen. He went through the whole lot and categorized it into about 6 different regions. And then I obviously analyzed the FDG PET. And we were really confident that, 20% of those lesions, the actual cancer that was found wasn't actually FDG Avid.
Interesting.
So it was either benign. So of those 3, one was misclassified, and the other, and he really, looked at that very closely. And the other 2 were actually, there was a benign lesion elsewhere in the thyroid. But the problem is that, we see the PET scan, we do all of investigation, it's biopsied, it's done, and then the surgical report just comes back and it says it's thyroid cancer. And we don't necessarily go back and say, oh, it was in this particular region and whatnot. And so I think that is something that is there. And it's, I've got that from my series where it was 20%, but it may well be evident. There was the other case series where they excluded the microcarcinomas, and again that altered that. So I think that's probably my best guess. The other thing is we just don't know. All of the studies, they look at malignant disease and the significance of FDG avidity on prognosis, and it may just be that in localized thyroid cancer, which by definition is what an FDG Avid Thyroid Incidentaloma is, when you resect that, for whatever reason, it just may not have that same prognostic significance, because those lesions, they may be the FDG Avid thyroid cancers that don't necessarily have a predisposition to metastasizing and causing further morbidity. That's just a hypothesis. I don't know, but that's just another possible explanation, because it is a different cohort actually of patients to those that have got metastatic disease, which is where we look at most of those studies of FDG avidity and prognosis.
Right. Terrific. That's a great explanation here. I think for those of us who aren't living in the nuclear medicine world, understanding that the potential biases of interpreting those studies is really, really important. We do have a question from Dr. Chen regarding PET-CT follow-up for confirmed micro papillary thyroid cancers that are treated without surgery. Do you have any thoughts regarding that?
So I think microcarcinomas, so that are being managed by active surveillance, I guess the guidelines would be actually probably more ultrasound surveillance. The concern would probably be more regarding local progression than distant spread in many of those cases. So I'm not sure that the FDG PET would be useful, particularly given the radiation exposure associated with that as well. If we were surveying a microcarcinoma, we do it with ultrasound rather than anything else.
Great.
Yeah, I'd agree with that. And I guess in my talk, when I talked about FDG PET, it was more for ongoing surveillance or for investigation of the underlying malignancy if it was being used for that rather than for the thyroid cancer.
Terrific. Well, I want to thank both of you. This has been a terrific session, really educational, and really provides a great context for managing these incidental thyroid FDG Avid lesions here. So I want to thank you both, and I wish everybody who's joined us today to stay safe, and hope that you'll be back again next week here. So thank you all very much.
Fabulous. Thanks,
Thank
Mark.
you.
Thanks, Mark.